Good afternoon, everyone. We are about to begin. My name is Anne, and I have the pleasure of being the chair of the championship. And it is my pleasure now to introduce it, if I can find out how this works. We now have the 3 teams ready for competing in the finals. It is this is the agenda for it. So we decided in no particular order, but it's the pre-hospital central region, Denmark first. Then there will be an intermezzo where you will get some education by Morten Bødker. Then Falck, Denmark, will be the next competing team. And in the next intermezzo, you will hear Richard Lyon. And then the third team is East Midlands Ambulance Services from the UK. The judges for this final is Fiona Moore from UK, AJ Heitman from US, and Ron Brendel from the Netherlands. You will also see the instructors, Peter Burlack, Bodil Thorsager, and I go around a little bit. So this European championship, EMS Championship, is organized by the Copenhagen Academy for Medical Education and Simulation, together with the EMS Services of Copenhagen, and sponsored here by Lærdal, Falck, and iSimulate. In the initial round, we also had quite a lot of instructors and judges, and I want to thank them all for participating in this. It's actually quite a job, and they set aside other assignments and lots of time to do this. So thank you very much to Bodil, to Peter, to Ron for being instructors, helping write the scenarios, to Arndt for also helping out, and the judges, Jan Torsten Gresner, André Gnierke, YY, Stefan Polocek, Michael Sayer, Tony Walker, Peter Burlack again, Ron Brendel, who also served as judges, Vinay Natkani, Andy Lucky, James Ward, and Richard Lyon. I hope I did not forget anyone. And then I want to really give a big thank you to all our volunteers. They've been practical. They've been practical helpers. They've served at simulated patients. They've served at hosts and hostesses, and it just couldn't be done without their help. So for this, the scoring will be based on a combination of 2 elements, just like in the initial rounds. It's based on the technical assessment and treatment of the patients, and it's based on the non-technical treatment also. The non-technical skills the teams will provide. And it's on scoring sheet, so we do it as objectively as we can. There will be some awards. The awards for the championship, the team with the highest score, of course, will win the award, and that will be a trophy, together with free admission to the next EMS in 2019. And there will be an audience award. Also, this one will be based on your voting. So after the last team has been on stage, you will open the app for the conference, and in this it will be possible for you to vote on the team you think should win a prize. Both these awards will be announced tonight at the gala dinner. So how to vote? I think we will take this again after the final team, but you will find your EMS 2018 app, you will open it, go to the agenda, find the championship finals, select EMS Championship voting, and then select your preferred team and push vote. You can only vote once and for one team. But we won't open it now, because if you made up your mind already, it's cheating. So, with this, if we are ready, I think we are, then let the games begin, the finals begin.
Emergency Medical Services, how can I help you?
I think there's been an accident. It looks really bad. I think we need an ambulance.
Okay, can you tell me how many people are injured?
I think it looks like about 4 or 5 people maybe.
Okay, the ambulances are on their way.
Okay, team Middle Region Denmark, you ready to go?
Yep.
Okay, guys, here is the dispatch signal to you. It's an A1. It's a shooting incident, a car accident, multiple injuries. The shooter has fled the scene. The police are on scene and say it's safe to proceed.
Could you just repeat it once more?
Absolutely. It's a shooting. It's a car accident, multiple injured, the shooter's gone, the police are on scene, they say it's safe to proceed.
So, scene safety, and there's a shooter, and a car accident, and multiple injuries.
Let's go for it.
Hej, det der. Hello?
Scene safe.
And scene safe? Good visibility? Yeah. Police, you have some sort of... what's going on here?
We have 5 injured.
5 injured? Yeah?
Let's put the stretcher here.
Yeah.
Yeah? And you're sure there's no more around the audience than no one? It's totally 5 persons in total?
Yeah.
And you are completely sure about that?
That's what we have seen.
Okay. Dispatch, I need 4 more units. We have 5 casualties. We're the only one unit here. I like ETA on the next units. Team, equipment here. Yeah, thank you. Yeah, perfect. Okay, we're going to start over here. Team, yeah? Yeah? Okay, Kim, patient 1.
Yes.
You start him?
Yes. Okay.
He's been shot.
Hello, sir.
Are you
Can you
okay?
hear me?
Yeah.
Do you have any pain anywhere?
Checking A.
Oh, no, I'm okay. I'm just
Yeah?
a bystander.
Maria, number 3 on him.
Clear and threatened. Do I hear any breathing?
Here you go. Put this on your
Patient
arm.
1.
I have some breathing.
That's 1.
Do
Sir,
I
you're
see
patient number 2.
any massive bleedings?
Marie, we're going to continue.
Do I see any massive bleedings? I see
Hello?
what I see.
We have more injuries here.
Yes, please. Can you sit
Yeah.
here
How are
and
you?
keep his head like this? And
Yeah?
and
Yeah.
listen
And
for
you,
breathing.
sir, you are right as well? Yeah, okay. Marie, you're going to take care of the first child here. Patient number 3.
Child
Yeah?
number 3.
Is this child responsive? He's crying? Yeah, Kim?
Yes. Patient 1,
Yeah?
unresponsive,
Yeah?
breathing,
Yeah?
no bleeding,
Yeah?
movable,
Yeah?
priority 3.
I'm putting in
3. Okay.
OPA.
Kim, you take care of the kid there.
Yes.
It's not working.
Hi.
Okay.
I have to look at
No
your
breathing,
child.
shallow breathing.
Yeah, can you please move
Breathing
a little
stop.
bit away?
Trouble breathing. Yeah?
No, it's not breathing.
Police, police officer,
Team
can you
leader.
please come help me?
Patient number
Yeah.
3 is
I
not
have to-
breathing and the OPA
Can
is
you
not
take him a
working.
little bit away?
So expected. Yeah.
Expected.
Yes. Can you help me?
Green card on
please?
us.
Take your child here. Take
Marie?
your child here.
Yes.
Something
Down,
changed
sit
about the
down.
breathing over the
Support
police.
the child here.
Yeah.
Yes, and at the count of 3, we turn it around on the back. 1, 2, 3.
Yeah? Policeman, what is the status right here? His leg is hurt. Yeah? Okay.
Shallow breathing.
Have you got any
Hello,
more police
hello, can you hear
resources
me?
here?
Have a
So I'm just going to move your foot here.
Unresponsive child. Looking for anything in the mouth. No. Breathing. He's crying.
Yeah, I see that.
So
Yeah.
he's crying now. And breathing
She was
okay.
shot as well. Okay, there's
Okay.
pulsation
Do
bleeding
I
here.
see
Team
any
leader, I need
Yeah.
some
major
help.
bleedings?
Yeah?
No major
Ma'am?
bleedings.
Yeah.
Can you just sit and calm him down? He's okay now. Yes.
Well, who's your
It's
boyfriend,
a
ma'am?
gunshot.
Over there. He was shot.
Yeah, he's over there. We're taking care of him as well.
Team
Do you
leader?
have any
Yeah.
equipment?
Yeah, det er fint.
Do you have any
child?
oxygen?
Yeah.
No, nothing. Could you please get the big
He's responsive.
blue bag?
A alert.
Yeah.
Breathing.
It's a big
No
blue
bleeding.
bag,
Yeah.
please.
Priority 3.
Yeah.
Movable.
Okay. Then go and help. No, Kim. Start with this lady here.
Yes.
Just go through her. Just put a Tony K on. I had prior to her. Just.
Okay.
Yes,
Hello,
thank you.
hello, madam. What's your name?
Okay. Marie.
Oh, I have an
Team
A,
leader, I have
3A.
a beat problem. He has been shot in the chest.
Yeah.
No, nothing at all. No.
I'm putting
I
oxygen
have to cut
on.
you close to look how it looks.
Do you know how to use this,
Do I see any
policeman?
major bleeding here
No.
now? Or is it stopped?
You put this on.
Yeah.
And you just help him
Okay.
breathing.
Scanning lung. What do I see?
Try to take.
Yeah.
Yes.
Here.
Just one moment. I have to talk. With
Clear breathing.
you. Do you
Air going out of this wound here. Nope.
No.
try to breathe? Yeah. Does that hurt?
Is he still breathing?
No. I'm looking at trachea. Do I have normal? Yeah. Looking at the vein.
Can we puncture this doll?
Okay. Any bruises on the chest?
Okay.
Yeah.
No. Nothing.
Suspected tension pneumothorax. Second,
Yes.
third rib,
Team
mid-axillary.
leader.
I'm going to puncture.
Team leader.
Yeah.
I have a
I
person
don't get
being
through here.
unresponsive over here. We have not checked.
Come on, clavicular. Yeah.
Okay.
Yeah. Okay.
So
No, that's it, yeah.
hemorrhoids.
Listening
Yeah.
for a long time.
Immediate release here.
Listening.
Thorax movement.
Okay.
Yeah. Perfect. Continue with the.
Yeah. Team leader.
Yeah.
I have a beep problem with the guy with the police officer.
Yes. Marie, you continue here, and I'll go back to you.
Yeah.
And capillary response.
I'm starting from-
Policeman, how is the status here?
Okay.
Is he
He's getting white in the face.
breathing?
Okay, yeah.
And her pulse
Kim.
and skin.
Kim.
Yeah.
Okay.
The chest is
I have
rising.
the patient here
And
has
it's,
no problem now. We have fixed
stable.
the problem.
Perfect.
The chest
To
is
this
stable.
patient. He's getting
And
pale
it's
where the
same
policeman
as
is.
rising.
Yes.
Ma'am, if she loses her consciousness, you
happens?
can come and
On
find
this
me.
side?
Yeah.
Tell me what happened.
That's the left side.
We are looking at your primary responsibility right now. Looking at her, we're taking care of the rest. So if
He's awake
changes
now.
in her
It's
behavior,
getting blue,
come and
you
contact me.
said, or changing color. White in the face. Oh. Hello, sir.
Yeah.
Can you hear me?
He's crying a lot. Yeah,
Can you
ma'am.
hear me?
He's been into a terrible. He's
well,
not
well,
feeling
well.
quite well right now. Your primary concern right now is taking care of your son.
And how
we know he's been to an
fast
accident.
is the breathing?
But the child, and it's excellent. You just take care of him now.
breathing
As
is
long
okay.
as he's crying, that means he's okay. We come back to you as soon as we can. You're doing excellent job, man.
Can you hear me, sir? It hurts. Where does it hurt?
Hvad siger du, Marie?
Is it okay? I've cut everything.
Damping. Okay. It's not like a drum. It's like a bucket full of water. Yes, okay, thank you. I think it's a
IO?
hemorrhage he has.
Can we do that?
Looking at
Left leg? Okay. Would prefer the arm. Simulate doing. Okay, we simulate doing it in the left leg. IO in.
Do you have the...
Yeah, but we're simulating. I think we're not doing it. We just flushing through and aspirating, pulling back blood. Yeah, it's working. Yeah, administering tranexamic acid 1 gram.
Do I feel a pulse here? In the arm?
Yeah.
On that arm, yes. How
Is he
is
still
it?
breathing, policeman? Yeah, perfect. Marie,
I'm
I go back to you.
very ready. Yes, I go further down. I feel the stomach.
Kim?
Team leader,
It's
I
soft.
have a B problem here.
B?
He has
And I
crevices
feel...
on the left.
Perfect.
I
I
will
just
go up
bring my
and stop.
ultrasound to you.
I will feel the head blood.
Ma'am,
Yeah.
you're doing
Can
excellent
you
job
sit
as well.
here in the front of him?
Yeah, you're doing
Put
excellent.
your knees on both sides of his head.
Scanning.
And stabilize his head. Thank you.
Normal on both
also-
sides. Yeah.
Also take your hands around his head and see if there's any
Same
bleeding
to
on the head.
his left side, but long movement on both sides. Yeah. Scanning hard. Feeling the tension pneumothorax. Normal. Okay, Kim. Kim, we only air here, so there is a suspected pneumothorax, but there's equal movement, there's long sliding both, so we don't need intervention right now.
Okay.
Yeah. You come back to me if there's more problem.
Okay.
Yep.
Do I see anything here? Looking
Behind the ears?
No.
long pain at the pelvis.
Ma'am?
Yes.
Ma'am? Yeah.
Yes,
We're taking care of the
anything here?
boyfriend right now, and we get back to you as soon as possible. Right now, you need to stay where
Oh,
you are.
yes.
We're doing all
Okay.
of we can to do.
Anything
You're
here?
doing an excellent job, ma'am. I can. He's hurt. Yeah, he's hurt.
Okay.
Is that your boyfriend? No.
Check
Different
your
one.
nipples.
Okay. Please, sir. Come on. Yeah. If you stay where you are here, it will be perfect. Yeah, he's hurt. That's the information right now. And we're doing what we can to help him, and he needs to stay there. And
Team
policeman,
leader. Team leader.
right now,
Team leader.
if I would like you to help this woman over there with the child. She's very
I'll just go for some
disturbed right
oxygen
now.
for
So
him,
just
and I'll be back, okay?
help support her. Yeah, excellent. And you're sure you're not hurt anywhere?
It's shallow, the same.
Kim?
Yes, I'm looking for oxygen. Is that used?
Oxygen is used. Yeah, you can't get oxygen. Yeah.
Do we have any extra oxygen in here? Anyone?
Policemen,
Firefighters?
Policemen or firefighters, do we have any oxygen?
Oh, he's breathing.
No.
No oxygen. Okay.
Take one in.
I need the bag.
Yes.
Back.
Yeah. Okay. Is he still alive?
Team leader.
Is it
Yeah.
bleeding?
Team leader.
Yeah.
As you see, so
I
it's
have
not
a
bleeding anymore.
I have a patient with pelvis. I
Yeah.
suspect bleeding. I want to use plasma and
Stable? Good.
Samsling.
Yeah.
The thighs?
Inserting IO here.
Are you inserting the IO?
I'm inserting IO.
Okay, I'll fix the plasma.
The leg here.
IO.
Open fracture, but the thighs is nothing. It's as I'm seeing.
Giving tranexamic acid 1 gram. And testing IO functioning. IO functioning here.
Good.
I
Thank
can
you.
administer plasma, and you can continue with this one.
Yes.
Yeah.
And just a friendly question.
Yeah.
Have you looked all around the car and under the car?
Nope.
In the trunk?
Nope.
Everywhere?
We have not done that because we have
Okay.
no. But I'm going to do a full scene.
Thank
Okay.
you.
Yeah. Look into the car. Do I see any more persons in here? Do I see anyone in the trunk? No. Lots of glass pieces here. And no, I can look into the trunk, but I don't see anyone.
It hurts.
Okay,
very
Kim.
much.
So basically, no more hurt persons.
Yes,
Marie,
team
can I do
leader?
it? Yeah.
Can you help me put on the Samsling?
Yeah.
I feel the arm.
And I'm also thinking about giving him tranexam.
I can give. It's already administered.
Okay.
So
You wanna-
sampling.
Yes, and maybe a little fentanyl held it.
Yeah, not fentanyl yet, but yeah.
Okay.
Okay.
I put it under.
Yeah.
Okay. Going to the other side
Yeah.
for sexing.
Do I see anything?
Ma'am, sir, I'm just
Doing a
going to
good
move a
job.
bit here.
Okay. One.
you see anything
two.
beside this?
1,
2,
One.
It's bleeding as I
2.
see it.
I think you're there, right?
1.
The bleeding has
Can be.
stopped.
Okay, we're just going to simulate it's going to be put on.
Okay.
Okay, we don't, yeah. No clicks, but you, until, yeah. It's fine, there, Kim.
Click.
Yeah. Classical click sound. Okay.
Good. So now I have a person. A is okay. Breathing is okay, but crepitation on the left side.
Yeah.
Do you want to see if it has changed?
No,
Okay.
right now, as long as his state is not, I can, I'll do a second ultrasound of the lungs.
Okay.
How does his is it cyanotic or does it look good? On the lips, noses, ears. No.
Still lung sliding? Sorry? Yeah. Normal lung ultrasound, Kim.
Yes.
Yeah.
Okay, I have a minor problem down here with a
Yeah.
broken leg. I see.
And still
bones.
crying for this child? The crying I hear is from him. Yeah.
Getting
Okay.
air in.
The little baby's just lying right there. We can't do anything for him right now. So you're just supporting the female there.
There's no massive bleeding down here, no?
Marie?
I have
There's no massive bleeding, it's like I see it.
the other one is small.
Okay. So
And he's a very shallow
Okay.
breathing. I want to put him on the side because I think it's a hemothorax he has.
yeah.
Okay.
We're just going to try to
putting
release
really light
some of
sometimes around to
the
make sure it
the
doesn't
blood
get
in his thorax as well.
Yeah. It's a very
Shallow
shallow.
breathing and unequal pupils. Marie, you're getting trouble breathing? Getting air in him?
No, that's getting air in, but his breathing is very shallow and
Yeah, so
very
you're
slow
just
now.
supporting the breathing and there's uneven pupil?
Yes.
Okay. Then this guy is our most hurt one. Have you tested the fracture of the leg? The leg is moving?
I haven't checked if it's moving, but I have checked the whole body.
Okay.
It's only these two fractures, and it's not bleeding
Do
anymore.
I feel any movement or loose parts here?
No, that's normal too. I have checked it, and that's normal too.
Yeah.
The pelvis is stable,
Perfect.
so I think the big
So
problem
this
is
position of the
hemorrhage.
leg here is normal?
Thank you. The simulation is over.
Så de får ned efter narkomadras til at lige løbe den rigtig ned, og så med vattenmadras og sådan. Det er derfor, jeg stod ved siden.
Okay. Team leader, could you get your crew to clear up after themselves, and then I want to borrow you for 30 seconds, okay?
Yeah.
So, if you guys, you start cleaning up your mess, I'm going to borrow your team leader. So, 30 seconds, tell me, what's your plan?
Yeah. The plan is, my most dangerous person is this one. We are stabilized the most of them at the way we can. So advanced airways management and his first priority movement. He's going to have be intubated, and we're going to do some definitive surgery on the hematology on the bleeding on the side to help him. Because of dilated pupil, he's our priority one.
Right. You've got 10 seconds left for the rest of the patients. What are you going to do?
Okay. Dead child, trauma unit, and the trauma unit for her as well.
Okay.
And there's the man is also, because he's shocked, and also the rest is going for shock treatment as well.
All right, and you have how many patients?
In total, I have 1, 2, 3, 4, 5. I think I got 6, but now the patient is moving for me. 1, 2, 3, 4, 5. Yeah, and I've counted the first one. So I have 6 in total, including him. He's all right.
Okay, I think we'll stop there. Let's give him a huge applause for him and his team. Thank you very much. And guys, all right guys, grab your kit and out this way please. Thank you.
Well, thank you for that. And while reorganizing the scenario, the setup, we have reached the first intermezzo. So it's our honor to present Morten Bødker. He's a consultant pediatric anesthesiologist from Rigshospitalet Hospital, Copenhagen, Denmark. He has a vast experience from pediatric trauma and airway management. So put your hands together for Morten.
Thank you so much. I need to correct you. Nobody has vast experience in pediatric trauma, but I've thought about it a lot, and that's what I'm going to talk about today. Doing a talk in 50 minutes on pediatric trauma is quite a challenge. I've tried to pack it as tightly as possible, and I'll try to home in on a couple of important aspects, at least in my book. I have nothing to disclose, and this is what we're going to talk about. Basically, the key aspect in doing pediatric trauma is to prepare effectively. You need to prepare within the aspects of the data and then finding your equipment, and also need to prepare in order to have your equipment ready. Also, I'll try to give you a toe-to-foot walkthrough on the most predominant aspects of anatomy and physiology and how kids differ in comparison to the adult. So let's go. Basically, when I did this about 10 years ago for the first time in Copenhagen, the trauma center, I was struck by the fact that we didn't have any guidelines, and that made me a little bit uneasy. And the solution I selected was to do my own guide. So basically, I made this fact sheet, and you could see it on the screen up here. This fact sheet, which basically the idea was to have a fact sheet that comprised all the data you needed to know when you were about to prepare for a PED in the trauma center. And I made these 26 data sheets from age 0, weighing about 3 kilos, until age 10, weighing about 28 kilos. And they were a huge success. And one of my colleagues, Michael, said, let's make an app. And we made an app, and this is how it works. Basically, you can see there's something. Oh, this is how it works. This is my smartphone. I activate the COPE app, and you can see on the top screen you can slide between different sizes and weights, and you have a vital stats. You have something about intratracheal tubes and airway equipment. There'll be some guides guiding you to draw up the correct drugs in induction and airway management, and also in cardiac arrest. And this app, the Danish version and COPE, has collectively been downloaded about 10,000 times plus, and we're working on a more cool and interactive platform, and it will be news about this in the fall. Also, you need to have some kind of aid when you need to find your equipment, and the EMS here in Copenhagen, they have this kit. Basically, it comprises of one bag with 4 bags inside, a base bag with laryngoscope blades, and also some basic equipment, and also this age-specific bags. And you can see what this looks like. In comparison to earlier versions, this bag has all the equipment packed in the sterile wrapping, which is a benefit in order to provide safely and effectively for the kids. Now, I promised you a head-to-toe assessment or a head-to-toe walkthrough, and the design of these slides is a left column with how children differ, and a right column with assessment and to-do tips. And the first slide will be all about the head and A. Basically, kids have a large head compared to body, and it has some of that gives rise to some of the challenges of the kids, because this large head is supported by the body by a relatively weak supportive tissue, and this head can bob around and cause injury to the head, especially if the kid is fastened in the seat and the car has a dramatic stop. Airway-wise, the kids have this really big occiput, and once you place the kid on a firm surface and you do not take this into account by putting some padding under the shoulders, the kid will have a tendency to flex the neck, and this can cause airway obstruction due to the tongue obstructing the airway by having contact to the posterior wall of the oropharynx. Also, the nose is relatively narrow. The glottis is relatively high rising, and also the epiglottis is quite floppy and omega-shaped and can make it difficult for you to intubate. Also, the trachea is relatively narrow and very, very soft. So having the idea that you can easily do a front-of-neck airway access with a cannula and jetting is faulty. You shouldn't expect to be successful in that strategy. So what can we do? We can assess airway patency by looking, feeling, and listening for sounds, looking for seesaw respiration, and you have to do some strategies. We have to have some strategies to stabilize the airway, and obviously, by doing this, or while you're doing this, you mobilize the spine. You do the padding, which I talked about earlier, and you have some really nice techniques you can do without intervention by putting something into the throat or mouth of the child. It looks like this. This is actually a demonstration of how you can do an effective airway opening and mask ventilation without putting any adjuncts in the nose or the mouth. So opening the mouth of the child, applying the mask, and rolling the mask over the face of the child, and applying nothing else than jaw thrust. No chin lift. Chin lift closes the mouth of the child. So jaw thrust, opening the mouth, and keeping that position makes it quite easy to ventilate most children. Also, I'm a really big fan of CPAP. CPAP is a powerful technique to open the airway in children with upper airway obstruction. This kid has hypertrophic tonsils. And simply by applying some CPAP, you can see the airway opens and the child can breathe freely. This also goes with the anaphylactic child, the child with inhalational injury. So try using the CPAP. It makes wonders. Okay, B, and thorax. What can you say about thorax? The child thorax is soft, the ribs are horizontal, they are primarily diaphragmatic breathers, and that's why it's a problem if you do not do a good job opening the mouth during doing ventilation. You will pull a lot of air into the kid's bowel. This will displace the diaphragm and make it difficult for the child to breathe. Also, the FRC is reduced and the oxygen consumption is high, so they desaturate like lightning. This kid ended up under a reversing truck a couple of years back, and you can see these skin lesions. And he had a double pneumothorax. He had pulmonary contusions. He had a liver lesion that almost killed him, but he had no rib fractures. None whatsoever. So this just gives rise to underlines my point that ribs are really soft and pliable in this age group, and the absence of rib fractures is not absence of severe trauma. So assess breathing, assess saturation, and what can you do? Oxygen, of course, decompress the bowel, recruitment, and also needle decompression in case of pneumothorax. Circulation. We talked about COPE, or I talked about COPE before, and the great thing about COPE, it helps you remember what's different from different age groups, and that's what circulation is all about in kids. It differs. It comes in all sizes, and vitals, they vary. Also, vascular access can be quite difficult, and it's relatively common that a kid arrives at the trauma center without any peripheral venous catheter, and I suspect sometimes my colleagues think, I'm just next to the trauma center, it might be okay to come without. But it's not that difficult. This technique is what I use usually. This grip actually makes sure that the kid's hand is quite immobilized, and the index finger secures the venostasis. Note that I'm using a relatively large PVC. It's a 0.9 millimeter in this 7-month-old hand, and it kind of works. Also, when you assess circulation, you need to address the aspect of organ function. I rarely ask for blood pressure during the initial assessment of a child that is arrived to the trauma center or pre-hospitally. I assess organ function. If the kid is awake, if it's crying, organ function is okay. If they're warm, it's okay. If the capillary refill time is fine, organ function is fine. Heart rate can vary a lot. If the kid is in pain, if the kid is crying or upset, heart rate will be high. It's not necessarily an indicator that the child is compromised circulatory-wise. So what can we do? Compression, load and go, usual stuff. Vascular access, I talked about. Obviously, IOs have a big role in kids as well. And tranexamic acid is also a player in the pediatric population, 15 milligrams per kilo. And sometimes, if we have blood products, also for the kids. Abdomen. They have a soft abdomen wall, so the relatively large organs are quite susceptible to damage. Also, bowel injuries are quite frequent in the pediatric population, and diagnostics is really difficult. If you have a child with signs of abdominal lesion and a circulatory problem, get to the hospital fast. Disability. You know this, a child is really looking distressed. Is it in pain? Is it just missing mom and dad? Well, sometimes you don't know, and it's really hard to assess. I'm a big fan of the alert verbal pain unresponsive approach to assessing children's mental state. I can't do the GCS pediatric, maybe the neurologist can. I've never learned. Basically, it's really important to stress whether the child, or assess whether the child is in pain. Still in Danish emergency facilities and also pre-hospitally, pain is overlooked. You focus on something else, and maybe the child is crying because mom and dad isn't there, but you need to focus on pain. You need to address this, you need to verbalize it, and you need to act on it. And maybe you haven't got the PVC, you have something else. Intranasal administration of drugs is the way to go, and fentanyl, 2 micrograms per kilo, is certainly a safe approach initially, and it has often a miraculous effect. And finally, exposure. You need to address, obviously, if there are any signs of fracture. The fracture profile of children differs somewhat from the adult patient. So if there is a long bone fracture, you might suspect that the trauma has a certain magnitude. Also, pelvis fractures in children is extremely rare. And does the kid have a pelvis fracture? You need to think if something really bad has happened. So assessment of the fracture, assessment of the body surface in total. And while you do this assessment, make sure that the kid doesn't cool down. Cooling down of the smaller children is a really powerful stressor and should be avoided at all times. So immobilize and keep the kid warm. So, if nothing else has been remembered, remember this. ABCDE is a universal approach, also for children. Guides are helpful. You can use COPE, use it almost daily, but any other guide that fits your needs should be utilized and implemented in your organization. And also have an appropriate equipment bag. Just something that fits your needs and takes away from some of the stress of preparation while going to the scene of the accident. Make sure that you take care of the kid's ventilation. Intubation is not key. Ventilation is. So have a strategy. Maybe use some of the tricks I talked about, but think about ventilation. And finally, make sure that the kids are treated in case they have pain. Thank you. Yeah.
Thank you so much, Morten. Unfortunately, we don't have time for questions this time.
Don't worry.
I just want to introduce to you the next team, which will be Falck, Denmark.
How can I help you?
I think there's been an accident. It looks really bad. I think we need an ambulance.
Okay, can you tell me how many people are injured?
I think it looks like about 4 or 5 people, maybe.
Okay, the ambulances are on their way.
So, Team Falck, you guys ready?
We are ready.
Okay, I'm going to give you a report now. This is an A1 mission. It's a shooting, and there's a car accident. There are multiple injured patients. The shooter has gone. Police are on the scene, and they say it's safe to proceed. You guys understand that? Okay. You got your kit?
Yeah. Got the kit.
Good to go?
Good to go.
Let's do it.
Okay. Okay, guys, stop right here. This is the evacuation point, and if the zone gets hot, we call evac and evacuate to here. This is also where we evacuate the patients to, okay?
Okay.
Yes. You ready? Follow me?
Ready.
Hi. The scene is safe. Okay, thank you.
We've got 5 victims.
5 victims.
Yeah.
Okay.
Don't know who's critical and so on.
Okay. How many guys are you?
We're 2.
Okay, only 2. No fire department or anything?
Sorry?
No fire department?
Not right now.
Okay, thank you. We have said that if the zone gets hot again, the shooter is back, we're going to say evac and then
and you
go over there.
Yeah,
okay, thanks.
You can use that if you want to.
Okay, thank you.
They are here. She's bleeding quite a lot.
Okay, John.
Yeah, I will do that.
Okay.
Is it Paul sitting?
Rasmus the kid?
Okay.
Yeah, kid. I'll get back to you, okay? Just going to go around and come back to you, okay?
Okay.
Shot? Okay.
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 I just pulled him out of the car.
Okay.
The head's falling.
Can you clear his airways? Open the airways?
He's still screaming.
Do we have any kit on you?
Yes.
Okay, can you open his chest and check him out and report back to me? Thank you very much.
The back.
Yeah. Will you?
This is stopped.
Okay, Casper. Okay. I've been involved in this.
You know, I was just coming by.
Check on her.
And I just saw the
Okay. Maybe we can assist the policeman?
Okay.
Okay.
Just stay here. Just talk to her, calm her down, and make sure she's still breathing and everything. If everything changes, call us.
He's still crying. You are not the mother person. Could you sit here? Yes. Still crying? Still crying, yes. Could you just sit here? Yes.
Okay.
Yeah.
Because what's the status over here?
The blood is stopping.
Yeah.
Okay.
You got the baby, the head has fallen off.
Okay.
The head has fallen off? Okay.
Yes. You got it.
Okay. Check the baby.
What?
Check the baby, please.
Check the baby. The head is falling off?
Yes.
Okay. Listen. It's gone. Okay. The head is falling off.
The child is crying. Okay. Still crying.
Still crying. Okay. Okay, John, can you assist the guy over there?
I'll do that.
Thank you.
Okay. What have happened?
Should I do something?
Okay. Listen.
You have to help her.
Yeah. Listen. Okay, John, have you been hurt anything?
You've been in an accident?
Okay.
Yeah. You just come by or...
We do whatever we can, okay? Okay.
Still
How's
crying?
he breathing?
Yes.
He's breathing like this? Okay. What?
Could you unfold this for me?
Let's see. Are you hurting from anywhere? Do you have pain?
Okay, can you cover it? Seal it up? Thank you.
No blood?
And report back to me again? No blood.
Thanks. What about here?
Good job, thank you.
Blood? No blood here? Okay.
Okay, at this point I want to call dispatch.
Here. Okay.
Dispatch.
Thank you.
This is paramedic 1. We are on a multiple casualty incident on behalf We got 5 injured, 2 children, 1 is dead. So we need backup assistance at this point. And we need 5 ambulances. And if you have physicians, we need those as well.
What about the leg veins?
Okay, do we have an ETA? 10 minutes, thank you. Okay, thanks a lot. Okay,
What is his name?
is he awake?
Joe.
Gravity pain?
Okay, thank you.
Stable?
Okay,
Unstable.
can
Okay.
you strip it up and see if it's a massive bleeding and report back to me again? If it's a massive bleeding, stop it, okay? Thanks. Okay, guys, Rasmus, John, 10 minutes, ETA 10 minutes to assistance. I've called the backup, okay?
Yes. Yeah.
Okay.
You have
Can you help over here? Yeah, if you could lay her down. Yeah. Okay, who are you then? Who are you?
Bleeding?
I was
Okay, her name is Jan. Can you stay with her and calm her down?
But she's asking about her boyfriend.
Okay,
She
okay.
wants to know.
Of course, of course. We will tell her, okay?
We're doing whatever
We
we
got
can
this,
right now,
okay.
okay?
Thank you.
Bodil, if I touch here, er der så hul? Altså i skamlen? Han er løs her i pelvis. Okay.
What about this?
What about the legs?
Massive bleeding or?
Got a bleeding here. Yeah, is it
So great? Awake?
Awake.
Okay, thank you. The bleeding? Okay, can you recheck for me the bleeding? Thank you.
Can you feel this? Can you feel this?
And dispatch, we need to call the fire department as well?
Okay. Nothing on the arms.
Okay, thank you very much. We need to stabilize the car and make sure it doesn't go into fire. Yeah, thanks.
Any blood on my hands? Yes. No blood down here?
I see some marks in here.
No breathing? Okay.
A little bit. We're just going to switch him to the side and look in the back.
Bodil, vi ser nogle mærker her.
Yes. 1, 3. 1 conscious.
Okay, try to open the airways.
Den føles normalt.
Middle there? Okay. Still no breathing? Okay, do you have a pocket mask? Can you check for pulse? The policeman can help you. Can you help him with checking for pulse? Just, thank you.
Jan?
Yeah.
Jan?
I'll get back to you, okay?
Yeah, I know it hurt. And it's unstable. It's not stable. Got a pelvis. Not stable.
Okay.
I got a...
Can you, is it still in? Yeah, okay. Can you assist John here with stabilizing the pelvis?
Okay.
Thank you very much.
What do you have to
Yeah.
go
What's the status over here?
6-year-old male
You take this one.
Okay.
with 2 open fractures on the
Just need to...
wrist. No more bleeding anywhere. It's only a little bleeding from the
Okay.
this little.
Okay, so the bleeding has stopped and is awake?
Yeah, it's small bleeding.
The bleeding has stopped and he's awake?
Yeah.
Okay, thank you.
And a head injury.
Okay.
Yeah, but still crying. Could you sit by the child there and talk to him? Yes.
Can you stabilize it?
His hands, don't touch his hands, okay?
Is that the...
Just talk to him. Calm way.
Yes. Is that pulse?
Do you want me to move?
No pulse.
Yeah, you can come with me. Can you observe here and call us if anything happens, anything changes? Okay, thank you. And you come with me, Rasmus? Okay.
Got no pulse in foot. No pulse.
No pulse. Okay.
Anything else you should do?
I'll get back to you, okay? Yeah. Calm her down, please. Okay. I think you should do a bilateral chest decompression here. What's the status?
His
Okay, but he's breathing. Okay, that's good. He's not breathing anymore. Can you check for pulse? Check for pulse. If there's no pulse, try it bilateral decompression. Okay.
What about just right? Check him, please.
Just dizzy? Okay.
Can I get you to assist the one over here? She has a bleeding that has stopped, and just reevaluate the bleeding for me on the girl over here. Thank you.
Okay. Keep talking to him.
Yeah. Do I hear anything when it comes in? Okay.
So the ETA on the assistance? 5 minutes. Okay. John? ETA 5 minutes to assistance?
He's unconscious. Okay.
He's unconscious.
Just hold his head. Thank you.
He's crying. Okay. Okay. That's a good sign. He's crying. Means his airway is open and he's breathing. Okay. Just watch out. Okay. Once in a while, just lift up and watch for bleedings. Okay. Thank you. Doing a good job.
Let's get some food, some oxygen.
Yeah.
Try to the needle to be suppressed.
Yeah.
It's only blood coming out. This. Only blood comes out.
Okay.
It's gone fast breathing.
Let's not do anything more about that right now. So.
Still normal.
You can come with me, Rasmus, when you're ready.
Can I feel a pulse?
You can come with me when you're ready. Okay. Weak pain? Oh, pain. Okay. Can you comfort him? Yeah. We will soon be ready to evacuate from here. The ambulance is on their way. Okay? Doing a good job. Okay, guys. Can you hear me while you're working?
Yeah.
Right now we have 3 patients to evacuate. 2 adults, male and female, and a child. And we will prioritize the one you have as priority 1 at this point. And priority 2, the child. And third priority, the female with the bleeding over here. Okay?
Yeah.
That's good. And ETA is 5 minutes to back up.
Do you want me to go over there?
Yeah, yes, this is John.
Yes.
That'd be great. Yeah.
Thank you very much. The simulation is over.
Okay, Jan, team leader. Could you just tell your team to clear up their kit? Then I want to borrow you for 30 seconds.
Okay. Can you clear up the kit? Clean the place, please.
So, Jan, just a quick answer. Yeah. What is your plan now?
My plan now is to await the backup, the ambulances that I have called the dispatch for, and then call the medical coordination center and ask them if they have any hospitals I will tell them about the patients and what kind of injuries they have, and they can give me some feedback where they are going. And I'll tell the ambulances that are coming, and I have prioritized the patients, and I will ship them away according to that.
Okay, just a quick question. Prioritizing which patient's going first?
The patient's going first is that guy, and number 2 is the child, number 3 is the female. And we have, fortunately, a dead child and a dead adult.
Okay, fine. Thank you very much. Let's give them a round of applause, people.
So, time for intermezzo number 2. It's a pleasure to introduce to you Dr. Richard Lyon. Richard is a professor at Surrey University. He's a HEMS consultant, and he's as well a consultant in emergency medicine at the Royal Infirmary of Edinburgh. So, put your hands together for Richard.
Ladies and gentlemen, good afternoon. You'll probably be very pleased to know that I'm not going to talk about sharp injuries or needle sticks, as the program showed. I'm going to talk to you about penetrating trauma, shootings, stabbings, just like you've seen in front of you. And this talk comes with a health warning. I am going to show you some graphic content. Please be sensitive about what you put on social media. If you are exhibiting signs of post-traumatic stress later, have another drink at the gala dinner, have another drink at the gala dinner. If you're still feeling bad, come and talk to me. I was on the car in London, enjoying quite a quiet day, just having a cup of coffee with my paramedic, and we got a call to say that a single male had been stabbed. This was the scene that confronted us in Oxford Street in London. An 18-year-old had got into an argument in one of the shops about the last pair of size 43 trainers. A gang member that you see in the puffer jacket in front of you had pulled out a knife, plunged it into the center of his chest. The patient had staggered out into the middle of the road and is in the middle of this crowd. You might just be able to see the police officers starting to do CPR. We arrived a few seconds after this footage was taken. And unfortunately in London, this has become a daily occurrence. 40% of the London HEMS workload is now scenes like you've just seen. And I said to some of my colleagues, I said, I'm going to Copenhagen to talk about penetrating trauma. Have you got any tips? And they said, yeah, sure, Richard. Your penetrating trauma talk should be as long as your scene time, i.e. really, really short. So I better just cut to the chase. The take-home message for your shooting and your stabbing patient, the only therapy they need is diesel. Just get them to hospital really, really quickly. And don't forget that. Your priority is to get in there and get out. Can you walk? Yes, follow me. Sit there. Shut up. We're going. You laugh, but most of these guys aren't usually in the frame of mind for sort of niceties. And actually, the evidence behind that is quite robust. Would you rather be slung in the hospital in the ambulance, albeit with me shouting at you, or actually, would you rather your pals just chuck you in a car and drive you to hospital? Well, the evidence is pretty strong. You want your pals just to drive you to hospital. You're twice as likely to survive if your pals just drive you with no intervention. Any intervention you do as EMS providers costs time. And time in penetrating trauma is not on your side. And I'll show you why. Penetrating trauma is made to trip you up. These patients are designed to catch you out. Why? You can look at that hole, maybe a stab, maybe a gunshot, and you say, I can see the bottom, no problem. Just put a plaster on, go to the local hospital. It's not that deep. Well, some of the weapons we're seeing now are really creative. It's not just knives and bullets. We see screwdrivers. What you see in the bottom right is a sharpened bicycle spoke. And we've got a gang in London, and they call themselves the Bicycle Gang, because they like to stab you in your arse. And I've seen patients stabbed in the arse die from a cardiac injury because the bike spoke has gone all the way through. We see patients now that have inadvertently had an ECG dot just put over the little hole that the screwdriver has made, and no one knew they were going to be stabbed. And when you have these patients, it's absolutely crucial that a torso stabbing might be on the back. It might be in the axilla. It might be on the neck or the groin. And you've got to get these patients completely naked and look very hard for even the smallest holes, because you can see there's a lot of really important structures that are very close and may be damaged. So what's your approach? Number one, just get a bit of control of that scene. I say you should bring some calm to the chaos. Then what? Nobody should die of external hemorrhage. Nobody should die of external hemorrhage. If they're bleeding from a limb, you must be able to control it. You must have the right equipment, whether it's a tourniquet or a hemostatic dressing, that if you see bleeding, you need to be able to stop it in the pre-hospital phase. Of course, these patients are very prone to chest pneumothoraces and tension, and no patient should have a tension pneumothoraces left untreated in the pre-hospital phase. Put your chest seal on, repeatedly examine them, be ready to decompress the chest. And of course, we know about the evidence from TXA. Get the TXA in early, but don't hang around on scene. It doesn't need to be given in the first few minutes. Get going, give it on the way to hospital. But what about fluid? Your patient has a systolic of 70, they're tachycardic, they're looking pale, they're looking sweaty. They often are. These patients have a horrible habit of hanging on till the very end. They're young, fit, and healthy, and then they decompensate. I would suggest to you that the only fluid you want to give is a blood product. Anything else will dilute their hemoglobin, dilute their clotting factors. By all means, put the big drip in, be ready, and don't look at the numbers. It doesn't matter if the patient has a systolic of 70. If they're cerebrating and they're talking and they're with it, that's enough. Any more and you risk popping off clot and causing more bleeding. You don't believe me? Well, if you work in the pre-hospital arena, you must have read this paper. It's crucial. This randomized trial from 1994 just took patients that we've seen who have been stabbed or shot with a blood pressure of less than 90, and they said, right, we're going to randomize to as much saline as you want pre-hospital or nothing until they get to the operating theater. And those that got nothing had a much higher survival to discharge rate. So you've got to be prepared just to hang fire and treat the patient, not the number. Now, in the video you saw, that patient was peri-arrest. And just as there is an algorithm that you will all know and you will do all the time for medical cardiac arrest, so too is there one for traumatic arrest. And you need to be prepared for this and have a system for working through that. And if you look carefully, the first step of that algorithm says if the patient has a cardiac arrest from a penetrating trauma injury, you need to consider resuscitative thoracotomy, especially when that arrest happens within 10 minutes of the provider being on scene. Now, in hospital, they make this pretty complicated, and that's the thoracotomy tray that is in my resus department. In the pre-hospital scene, we like to keep things nice and easy. And that is all you need to save this patient's life. The patient you saw in the video had a single wound to their right ventricle, a little bit like this one. Now, this is quite tricky. You see, when the pressure is released from the heart, every beat of the heart is ejecting hundreds of mils. You're not going to survive very long unless that blood is contained in a tamponade. And clearly, the surgeon here is desperately trying to fix that hole as fast as possible. Now, trying to do this through a tiny little hole is pretty challenging, as you can see at the best of times. In the pre-hospital phase, we need to make things as simple as possible. And that means making a big hole. Taking a knife, cutting along the red line to open the skin, and then using your tough cut to divide the intercostals between the ribs, cutting through the sternum to expose the chest. You can clearly identify a heart, a lung, and actually even for novices like me, I can kind of work out where we need to be going. It allows us to get in there quickly. It allows us to get access to the pericardium, and this is what tamponaded blood in the pericardium looks like. It's really thick. It's really viscous. It's not going to come out by sucking it out with a needle. You've got to scoop it out with your hands like jelly. And then the heart will start beating, and you've got to get that stitch in pretty quick. Now, you might say that's just butchery. You might say that's crazy. When we first started doing this, maybe 15, 20 years ago, we had a lot of pushback, a lot of negativity. Cardiothoracic surgeons said, no chance. This is just barbaric. But you've got to remember that actually this condition has a 100% mortality. If you wait until they arrive in the hospital, 100% mortality. They are always dead. So just in the spirit of this conference, you've got to dare to dream big. You've got to say, what does the patient need to survive? And what procedures can we do? And this is exactly what we did with this procedure. Today, 18% of patients that are getting this procedure on the streets of London, like Mark, are surviving. And that's because people in London dared to dream big, like you guys are in this conference. Think about the next step. What else can we do? Where else is the survival gain going to come from? And I was thinking about this. I wanted to be a doctor for a really long time, like a really long time. I wanted to be a pre-hospital clinician for a really long time. I was never good enough to be a surgeon. I'm pretty crap with my hands. I was never really clever enough to be ICU, so I kind of just did A&E. And the first time I was called to do this procedure on the street, I was really, really nervous. And I thought, oh my God, this is not going to go well. And I've done this a few times now. And I was reflecting last night, and I thought, you know, when you put the right training with the right pre-hospital equipment in the right system, and you're prepared to do these things, this is what happens. This was a patient I did it on 24 hours after he had his chest opened on the street of London. Ladies and gentlemen, next is now. There's now endovascular techniques, REBOA, different ways of managing penetrating trauma that a few years ago you never would have dreamt would be routine. And this is now absolutely routine for us. So ladies and gentlemen, I would ask you to think about the next time you're going to see a scene like you have in front of you. You've got to be ready to bring calm to chaos. You must minimize your time on scene, even if that means being really bossy and really taking charge. Control external hemorrhage and make sure your service has the right equipment to do it. Be ready to relieve tension pneumothorax and get the patient to someone who may be able to do surgery if they need it. And please don't flood them with fluid. Thank you very much for listening.
Thank you so much, Richard. I just want to know if we are ready. Looks so. The last team to compete in the finals is the East Midlands Ambulance Services.
emergency medical services. How can I help you?
I think there's been an accident. It looks really bad. I think we need an ambulance.
Okay, can you tell me how many people are injured?
I think it looks like about 4 or 5 people, maybe.
Okay, the ambulances are on their way.
East Midlands Ambulance Service, EMS, that's right?
Yeah.
Guys ready to go?
Yep, looking forward to it.
Okay, so here's your mission, guys. Blue light mission. It's a shooting incident, also car accident. There are multiple injured patients. The shooter has fled the scene. Police are on scene and say it's safe to proceed. Guys understand that?
Okay. Yeah.
Okay, let's go.
Do you want me to go first?
That's all right.
Okay, so walking into the scene, obviously looking at it from an edge of scene perspective, so you can see multiple casualties. So initially we're going to pop the stretcher at the side.
5 injured people, and that's okay. That's okay, no worries. It's going to fall off.
So James, if you go and assess on the right side of the car, and Ricky go to the left side of the car.
Hello guys, what's happening?
Okay, so have we got any bystanders that are able to assist us at all? You're a bystander? Okay, so if you're able to help...
Okay, put some pressure on there for me.
James over there, Ricky's here. Okay, so we've got the 2 bags there. Hello there, sir.
Right, okay. Are you 2 injured?
Okay, whereabouts has he been shot?
No, you're not injured. Are you injured? It's just your leg?
Okay.
Okay. Do you think you can get yourself
no worries.
up and around?
Okay, so initially, looking at him, okay, so what can I see? So assessing his airway. What can I see in his airway?
What I'm going to do is pop a little band around your leg, okay?
Okay, so a bit of stridor on his airway, so opening that up. Looking at his chest, so I'm going to try and get skin to skin. So, looking down the side of his chest while I'm looking, I can see an entry wound on the left-hand side.
No pulse.
And at the moment, I can't see an exit wound. I'm going to go down the trousers as well, get those off.
Okay, is there any breathing?
Yeah, if you're able to cut his trousers off for us, pal. Are you a bystander? Are you just helping me? Yeah. Just, okay, no worries. Are we all right? Just while we're here, just to roll him onto his back, see if there's any wounds onto his back at all. Okay, so just ever so slowly. Okay, yeah, if you're all right to, if you can hold his head, that'd be great. So while you're cutting up his trousers, I'm just going to roll him this side. So looking for any catastrophic hemorrhage. Okay, looking down his back, anything around his legs that I can see at the moment. So is there anything I can see on his back? No. Okay. So just going to go and grab some oxygen for him. If anything changes, just give us a shout. My name's Ross, okay?
So Ross, there's a kiddie in arrest, there's another one who's a P2, he's a P3, and I don't know what...
Mine's a P1 catastrophic hemorrhage, it's been addressed.
Okay, so how many patients have we got altogether?
So I've got 3 patients here.
3, 4... Okay.
So what are we doing with these guys?
So that's a P1 and this is a P2 here.
Is he okay?
So he's at arrest.
Is what?
Okay. Hello, can you hear me? Can you hear me? This boy is crying. Okay, that's okay. Okay.
So chest seal.
So, checking the airway, nothing in the airway.
Okay.
Any breathing at all? Okay, shall I start with resuscitation?
Thank you very much for that. Okay. So looking into his airway, so his airway was clear initially, looks a bit blue around the mouth, so I'm going to pop him on some oxygen.
Yeah, he's dead.
So,
you okay there, James?
Yeah, do you want to help me with this little kid or so?
So I'm going to pop him on 15 litres of oxygen.
Is she okay over there
so
still?
catastrophic hemorrhage, I'm thinking probably internal, as you can see from the shooting.
My colleague's
airway is clear, I'm just going to have a quick listen to his...
Okay, so
pop the oxygen on, I'm going to have a quick listen to his chest.
Okay. So the airway, just looking at the airway.
Okay, nothing catastrophic.
Okay, he's still crying. Okay, looking for rise and fall of the chest.
Okay.
Okay,
Keep hold of
Any signs of injury on the chest?
Fabulous, thank you very much.
Okay, good. And then we'll do
Okay.
the radial.
So just
Still
keep
got
an
a good
eye on him.
radial.
Just going to have a quick listen to his chest. And then I'm just going to go and have a look at a couple of other patients. All right.
So if we expose him fully, can we see any signs of any injury in the torso or the arms?
Okay, you happy here?
Yeah, I'll do it.
You happy?
Okay, yeah. Okay.
You happy here?
Pardon?
Happy here?
Yeah. Have you got the? Can you go and have a look at the patients over there? Yeah.
Okay, nothing there.
Okay.
Okay,
So again, so I can hear breath sounds on the right side.
Okay, how we doing?
So right side
okay,
is.
let's have a quick
I
feel
can
of the
hear
radius.
left side is diminished.
Do you have a
Okay.
strong? Okay. All right.
Okay, no
My
worries.
friend,
So I'll go and grab
Okay. He's doing everything he can
cannula.
at the moment. All right. You
Pop that
just
in.
need to try and relax and stay there for me.
Good
Okay. This lady's going to stay with you. All right. Okay. If anything changes, give me a shout.
Okay.
Pelvis, is that normal? Okay. Long bones.
Okay.
Long bones, okay.
Okay. So this chap.
Both
What's
legs,
your name,
long bones
chap?
are okay. Okay.
Right,
No
okay,
worries.
what's the
So
tobacco?
he's just got a bump to his head,
Everything.
basically. Okay, no worries.
Okay, I'm just going
Is
to
he maintaining his
We're
own
just going to have a
airway?
look at see what's happening. All right.
Is he maintaining his own airway? Is he,
Okay, so he's on oxygen.
Fine, okay, that's fine.
So I'm looking for second intercostal
Is he
space,
your son?
clavicular.
Yeah. And your daughter. Okay.
yeah, we went down the long bones and the arms as
That's right,
well.
you just say
And he's
nice
got
and
a
relaxed,
fracture,
all
didn't
right?
say, here. Yeah, okay.
Okay.
Okay. Taking that feeler out. Okay.
Okay, examine
So
the chest.
I've got a shot.
Unfortunately, the kid is deceased with the amount of patients we have.
Okay, take a nice deep breath for me.
Okay. So I've got some blood coming out, so I'm
Michael,
thinking it's
take a big deep breath for me. Big deep breath.
hemothorax. I'm
Fantastic.
just
Nice rising force.
ease that in for a moment.
Some crepitus. Crepitus, okay.
James, Ricky, how are we doing, guys?
Yeah, it's all good here.
Okay. If you need us, give us a shout.
Equal rising force, look, it sounds normal. Okay.
So that's in. Also looking at this chest wound, so I've got some chest seal out.
Can the lad sit
Okay,
up
can
or
we
move?
go slightly moving that way so we can get his leg down? Is that okay? Okay, hold on, wait, it's got an open fracture.
On this side.
Okay, wait.
So with the little lad, can he sit up or can he move or do anything for himself?
Yeah, Ricky?
How you doing over there, bud?
Yeah, I'm all right at the moment.
Okay, so on this side we've got one catastrophic hemorrhage that's been addressed.
Could he walk?
Okay.
Which is okay, national, which is a priority one.
Okay.
Have we requested
Yeah, when he can't
backup?
walk, okay.
No,
I'm
just
just
saying,
thinking
can
if
we
he's
have backup? Obviously, we've only got
he can walk,
one,
then
two
we'll
vehicles
walk
here
in.
at the moment.
He could walk,
So
okay.
can we have backup of
He's
critical
only
care
got time.
paramedics,
Okay.
hazardous area response teams? Obviously, we've got significant
So,
damage,
is his mum
RTC,
bound?
and we've also got shooter, so it's a hazardous environment. Making sure that, obviously, we've got the police here, they're helping us out. This gent's holding this guy's head. So I'm just going to go and do a quick recce round. So I've got one patient,
So the kid is all right.
priority one, so patient one is priority one. Okay,
He's got an open tip.
so just doing a quick walk around. So,
Unfortunately, the kid's deceased.
okay,
This lad is he's actually walking wounded now, so he can
okay,
actually walk.
this lad's walking wounded.
Yeah. Ricky's just assessing this chap here. So we could
Okay, what about Dad?
Okay, go to our trolley. The bottom of the trolley, there's a big blue bag. Can you go and get that
Okay.
for me?
If anything changes, mate, give us a shout. All right.
That's okay. Just all right.
So Ricky, what have we got here? Just quickly, so I can try
So
and write
this
it down.
Ryan's got an open tib fracture.
Okay.
An isolated head injury and crepitus on the side of his chest.
Okay. Okay. So what priority are we, mate?
Okay. So my plan is to move him out, guys. Move him out, straighten his leg.
Okay.
Splint it, okay? Should we get some
Okay.
access and we can give him some pain relief?
Okay. No worries. If this kid's gone, Ricky's happy with this guy. Are you all right to just assess these two initially? They're looking at me. I can see. Yeah, they're fine. So you're all right to go around to that police officer, all right, mate? So far we've got. He's a P1. He's been shot to the left side of his chest. He's on high flow oxygen of decompressed flow of blood. So I'm thinking it's a hemothorax rather than a pneumothorax, or it could be both. No other obvious injuries I can see at the minute. James. Hello, guys. So what's your name?
My name is Stina, and this is Matilda. And
Okay.
I don't know. She keeps asking for her boyfriend.
Okay, so what I want you to do, just keep talking to her. Okay, we're just dealing with a few patients, so we're going to get everything sorted, okay?
No, I think it's the guy over there. She keeps asking for him.
Okay, we are checking him over. One of my paramedics is with him at the moment. Okay, so just looking in the car, making sure that there's no other patients in the car. Anything at all? And making sure that's safe and isolated. So with your leg, Ricky? Ricky?
No. Yes, mate.
Just quickly, what have we got?
She's got an isolated gunshot wound to her
Okay,
right.
P1 catastrophic hemorrhage, yeah?
Yes, P1.
Okay.
So any allergies?
Okay. So he's already had binging compressed here, so we can go the anterior lateral space as well. Can we go in that side, or yeah? I mean, ideally we could.
Okay, we'll get you some medication in a minute. Okay. Okay, at the minute you're talking to me, you're looking at me. Okay, you're doing really well. This young lady's going to look after you for a moment. All right. Yeah. Yeah, we will do. At the moment, there's just a few of the patients that we just need to see. Like I said, you are talking to me, so we're just going to do a few of the bits and bobs, and then we'll come back to you, all right, with some painkillers. Okay. Hello there, my darling. What's your name?
Sophie.
Sophie. Okay, my name's Ross. What part have you played in this? Okay, no worries. What do you know? Any medical? Anything medical at all? Do you work medically? Do you have any healthcare? Do you work in healthcare or anything like that?
I have a first aid course.
A first aid course. Are you all right to give me a hand and just help one of my colleagues over there, Ricky? He'll tell you what to do, all right? But it'd be great if you could come and help us. Ricky, this young lady's going to come and help you, all right? She's not medically trained, but she can do as you wish. So, hello, mate, you're right. So you're similar to the young lady over there, you're just a bystander. Have you got any medical training at all?
No, not at all. No.
Okay. Okay, no worries. If you're happy to stay here with James, okay. Anything he asks for, if you're all right to help him with, all right, and we'll go from there. All right, mate, you're doing really well. Okay. So I've just had a quick check round. Everyone's being dealt with at the minute, so I'm going to come and give you some painkillers. All right. Yeah, can do. Which one? This one. This young, are you all right to ask this young lady? Is that all right? Are you all right to help Ricky with that? I'm just going to get a line in this young lady and grab some painkillers for her. Yes. Yeah. So, what you got? You got blood pressure on that?
Blood pressure. Maybe some TXA as well. Look for an extra room. So I imagine this is the end. I'm going to give it to
Have we got any backup on the way? Or 5 minutes. Okay. Thank you very much. So I'm just going to use this monitor at the moment because the other one's being used over there. Normally we pop some pads just at your top shoulder and just around the left side. Okay. Is that all right? Normally I'll be able to do a blood pressure and a couple of other things, but because the monitor's being used over there and you're talking to me, all right, I'll just use this one. Okay, am I all right to,
Michael, how
am I all right to cut this jumper?
Pain doing, buddy?
Is that all right?
I'll put my hand on the back.
Okay, lovely, thank you.
Well, either that or if you can take it off, that'd be grand, actually.
Any blood?
Have you got...
Mark, I'm just going to pop some stickers on you, okay, on your arms and your tummy.
Thank you very much. Just while I'm doing that, just nice and relaxed for me. We'll pop this back on in a second. I'm just going to have a quick feel of your back and just looking, making sure there's no other injuries.
Just keep talking to him,
to see, okay. I'm just going to pop my hands just on the side here. Just nice deep breath for me. Okay. As it is. Abdomen. Abdomen looking out. There's no obvious bruising, anything like that. No worries. So just... Okay, put yourself up in that. I'm just going to go up to about here on your leg, just have a look at the wound. Okay. James, Ricky, how are we doing, guys?
Unstable pelvis. I could do pelvis.
Okay, so we have got
Thank
injury
you.
aside.
Is it in the front,
The
mate?
simulation is over.
Hello, mate. Jesus Christ. That was interesting. Sorry.
Okay, team leader. Team leader.
Hello.
Could you get your crew to clear up after themselves, and then if I could borrow you for 30 seconds?
Yeah, yeah. Cheers, guys. Sorted.
So, just give me half a minute. What's your plan now?
Okay, so plan from here is we've asked for further resources. We've asked for the hazardous area response team, which we use in England. We've also asked for doctors and ambulances. So far, I've asked for, I believe, 5 ambulances, or I might not verbalise that, but 5 ambulances. Basically, plan of attack from here is keep the bystanders helping and assisting. Unfortunately, we couldn't help baby, no breathing. Child here is walking wounded, so apparently has walked off. Is that correct? Or not walked off, walked to a helpful family member. This gent, Ricky's assessing, giving some pain relief, so he'll be taken to hospital. I would guess, due to the mechanism of injury, we would get him collared, longboarded, and transported with some pain relief. James, this guy over here, so we've got head injury, left-sided chest injury, so we're thinking internal catastrophic hemorrhage. Don't know how he's been involved with the car. Obviously there's some shooting marks on the car, but whether he's been hit by it at all. So thinking about C-spine. Airway was clear. Breathing, we put high-flow oxygen on him. Had listened to his chest. Left side was diminished or absent breath sounds, so we decompress that side. And obvious left leg injury, decreased level of consciousness. So all in all, he'll be transported to hospital, scooped, packaged, with 2 large bore accesses in, and assessed by the crew en route. We've got this gent here who was helping out, so yeah, just sort of helping with whatever he can.
Your time's up, mate.
And I can stop talking now.
Let's hear it for EMS. Grab your crew. We're going that way up.
Thank you very much. Could we have some light in here? And now it's time for you as the audience to find out who you want to vote for. So please open your app and go to the agenda, find the EMS Championship finals. Select the voting, the preferred team, and push vote. And then I want to thank the instructors and thank the judges very much for their tremendous work here. And also all the volunteers who can now get some proper clothes on. Actually, one thing I forgot, and that is to say thank you so much to our scenographer, Alan. Did you finish your voting? Did somebody not finish? No? Good. Then we'll close the vote. No, don't close the vote. Okay. So I guess we will close the vote in 2 minutes from now, and we'll go and find out who's the winner of the Audience Award and of the championship this year. Thank you.